uh, as we have started this topic, this book, Clinical Anesthesia Viva book. So today the topic we will be discussing will be about acute MI. Just tell me one thing. Have anyone faced ischemia or myocardial infarction in the operation theater? Any one of you?
Yes, sir.
So what are the usual presentations if you say that, because you cannot diagnose only on ECG, am I right? What will be the
Yes, sir.
usual sign symptoms if a patient is having ischemia or infarction? There may be hemodynamic instability.
Sir, agitated state of the patient firstly, then...
No. Dr. Kaval, we are talking about intraoperative. Come out of ICU.
Sir, no, sir. This is an ICU procedure. There was some fistula was ongoing under local anesthesia, and
Okay.
suddenly the patient developed MI.
Okay, that will be if, for example, if that patient is under regional. Okay, so even then, yes, okay, one will be, because I started with patient under anesthesia. Okay, so under anesthesia,
Yes,
patient will have either hemodynamic instability, arrhythmias, sweating. Okay, maybe you may be seeing failure in the form of pulmonary edema and froth coming out of endotracheal tube. Okay, so usually they may be, or in addition to that, of course, you may see some elevations or depressions according to the, but it's actually, unless it is very obvious, you cannot rely only on the monitor screen. Okay, under regional anesthesia, the extra things may be, patient may be irritable and pain, because of course there will be chest pain. Okay, so this will be usual sign symptoms which you can see either under general anesthesia or regional anesthesia. So what should be the plan of action? What you should do immediately? Yes, anyone? Anyone wants to tell, please?
Oxygen.
sir, first of all,
Okay, oxygen. Then
Nitrates, sublingual, vasodilator,
lingual,
vasodilators,
vasodilator. Why? Coronary.
coronary vasodilator.
Coronary vasodilator. Okay. Then this is sublingual.
Painkiller, something like
analgesia.
analgesia.
Okay. What else?
Hydration. Can improve a bit.
Before that, you are in an operation theater. Would you like to inform surgeon?
Troponin test.
No. Would you like to stop the surgery or inform the surgeon? So this is, you have to do, and then you have to
inform cardiologist.
You can send some enzymes. Okay.
Yes, sir.
Probably DCG.
Hormones. Yes, sir.
PPGs. Okay. What
Yes,
else?
sir.
Cardiology.
Yes, sir.
Okay. And any complication which is occurring, if you are having any arrhythmias, you will be treating.
Rule out the cause.
You will be, if the patient is hypotensive, you will be you will be giving some inotrope or vasopressors according to the situation. Okay, maybe you need beta blocker. Okay, because MI may be associated with hypertension, but ultimately, if the patient is going in the failure, then you might need need the support. Okay, so
sir, we can give antiarrhythmic.
Yes, you will treat accordingly.
Yes.
Whatever is happening, but general approach is like that, and then analgesia, and you you will increase the FiO2. So you're like you will avoid any stress which is there. Okay. So just a second. Just give me a second, please. Just a second, please. Okay. So we will just have a look in some of the aspects. Usually, in addition, like for example, in which wall, usually there may be conduction like blocks, conduction abnormalities block. Which wall? Yes, Dr. Kaval.
Sorry, sir, not accurately.
Like what supply? Usually, which like vessel supply the conduction system? Usually, it is usually right coronary artery. Okay, so right coronary artery inferior wall. So the inferior leads are these 2, 3 AVF. Okay, so there will be actually this is old guidelines. I opened this new one. This is STEMI. Like some of the aspects related to intraoperative and in emergency, because usually our aim is like either to do the primary cardiac intervention if there is no other contraindication. Okay, you will be you might need to stabilize the patient, immediately plan the patient, but in intraoperatively, immediately you need to finish the surgery, or you need to not finish the surgery. Like if the abdomen is open, it is difficult for the patient to be transferred there. So this will be according to the situation. But usually the aim is to either do fibrinolysis or primary PCI. Okay, according to the to the condition. Okay, but immediately what you can do, you can put an NG and give aspirin. Okay, you can give aspirin through NG. So this will be one thing you will be doing. Okay. What are different procedures they can do immediately? Either they can do only balloon angioplasty, they can do this bare metal stent or drug-eluting stent. Or if situation like that, maybe they can, because this will be a combined decision between the surgeon and cardiac surgeon and this cardiologist, that what will be, maybe even patient might need emergency cabbage. Okay, in addition to whatever inotrove vasopressors I told you, there will be one thing which may be needed, which is needed for support. What will be that thing that might be needed in certain situations? Can anyone guess? Mozama? Zagam, anyone? If like traditional things are not working, what will be the next thing you might need?
Intra-aortic balloon pump.
Yes, balloon pump. What will be the role of balloon pump in this scenario? What will it do?
So it will augment in diastole and increase coronary perfusion because coronaries are perfused in at time of diastole.
Very good. And what it does in systole?
Left ventricular function will improve.
Let her, Dr. Hamera, let her talk, please. Yes. What will it do in systole? It is called as counter pulsation.
Sir,
Okay.
counter pulsation.
So you told rightly that it contracts during diastole. So it increases the coronary perfusion. Okay. So this is one thing. And it just relax before systole and it decreases after load. Okay. It decreases after load and SVR. So this decrease the load on the heart and the contractility improves. Okay. So this is the rationale of balloon pump.
Sir, can we give a heparin?
Yes, fibrinolytic and antifibrinolytic as well as heparin. Yes, heparin, this tissue plasmin activator, or this one clopidogrel. There is one I think rivaroxaban they give. Actually, the name are very volatile. They forget. Okay, but usually they give antiplatelet. Just okay. So okay. So you see that time to decrease, if for example, like it will be depending on the situation. Okay. So as I told you that there may be arrhythmia, there may be hypertension, there may be hypotension. So you will be managing like that. If patient goes in failure, the patient might need diuretics. Okay. So actually in this, they are just trying to discuss that because there will be another scenario that acute MI or patient had previous MI coming for elective surgery. They have written the applications actually. Okay. This is the management. Okay, administer oxygen as I told, breathing if it needed, then might need to maintain the airway. Okay, and result will be either arrhythmia and failure. Okay, so if failure occurs, either it will be needing some support in the form as I told you that patient might need inotrope. Okay, so things will be okay. So like there will be signs either of heart overload situation or patient, as I told you, frank pulmonary edema can occur. Okay, and all these things raise JVP in hepatic engorgement, pitting edema. But practically, you might might not see all the things. It will be on different scenario, different things you can see. Okay, and this New York Heart Association classification and this one Canadian class. Do you know about it? Yes, Atik bhai.
Sir, no idea about the Canadian class, but sir,
There is no difference. The same here is for heart failure, and there is dyspnea, shortness of breath, and this almost the same with chest pain. Okay. So 1 and 2 is mild, and 3 and 4 is like failure. Like the 1 and 2 is compensated, and 3 and 4 is decompensated. New York Heart Association class 1 and 2 comes in the clinical risk factors or intermediate predictor, and 3 and 4 comes in major predictors or active cardiac conditions. Okay. Similarly, if it is Canadian class angina, it will be 1 and 2 will be in the like stable angina, you can say, or this 3 and 4 will be in unstable angina or acute coronary syndrome. Okay. So the like basic principle for maintenance or avoiding, and this is myocardial oxygen demand supply ratio. Okay, demand and supply factors. So Atik bhai, can you tell about myocardial oxygen demand supply factors? Heart rate, okay, preload, coronary perfusion pressure,
sir, there are
vessel
two
diameter.
factors. So can you hear me, sir?
Very less, very little.
Sir, let me check my mic, sir. Now is it okay, sir? Now?
Yes, it is better now. So heart rate is a factor, preload, afterload.
Sir, according to the question you've done, it is about it's the supply and demand, sir.
Yes.
And in the supply we will get about the perfusion, sir. And second is the
Atik
decision.
bhai, I'm sorry, we are not able to listen to you. Maybe you remove the headphones. Only then you will be able to speak.
Sir, I am not having any headphones, sir.
Okay, anyways, try to speak louder. So heart rate is one factor, preload afterload is factor, cerebral perfusion pressure, vessel diameter, basal requirement. Okay. So if heart rate is increased, coronary supply will be decreased and demand will be increased. So most important factor is heart rate. So if you want to check your anesthesia, just follow your heart rate, patient's heart rate. If it is not in the stable, it is going
Sir,
up.
can you hear me now?
There is
Can
too
you
much
hear me now,
noise.
sir?
There is too much noise behind you.
Sir,
Anyways, because
nothing.
actually I'm in a bit of hurry today. I have some guests at my home, so I just wanted to, because I committed that I will discuss this topic. So I'm just doing it. There are some things related to like acute MI management inside OR and acute MI management in the emergency. Okay. So there are some, we just discussed the baseline airway, breathing, circulation. You will inform the surgeon, you will try to contact the cardiologist who 12 lead ECG, cardiac enzymes, and maybe CPK, CKMB, trop T, trop I, it will be going high up, and you will like handle any acute situation, okay, in the form by giving oxygen, giving analgesia, any arrhythmia, treat any arrhythmia, you will start aspirin, and then you will try to minimize the surgery, and then you will transfer the patient for either primary cardiac intervention or revascularization. Okay, this is the basic message which I wanted to give you. So inshallah, tomorrow we will do some next topic. Okay, next topic. What is the next topic in this book? Airway assessment.
Sir, one thing.
Yes,
Sir, one
airway
thing
assessment.
left post MI limitations of surgery or anesthesia.
So that we will do it. We will do it
Okay,
in a
sir. Okay.
separate.
Okay, sir.
Okay, so thank you very much. Inshallah, we will meet again. Assalamu alaikum.